Good day. Today, the group will present their case study in connection with interdisciplinary dental approaches that talks about the treatment of hypodontia in adolescent dentition.
Let's learn first what are the diseases that possibly be associated in this case. First, we have hypodontia. It's a developmental absence of one or more teeth. Second, oligodontia is the term conventionally used in cases where 6 or more teeth are missing. And anodontia, a much more rare finding, describe the developmental absence of all teeth. Hypodontia in the primary dentition has no significant sex distribution, but in the permanent dentition, females are affected more frequently than males. Hypodontia may also occur with no hereditary history. Permanent first premolar, first molars, and canines are very rarely developmentally absent. Their absence is usually associated with severe hypodontia or oligodontia. Hypodontia may occur in isolation or in association with such syndromes as ectodermal dysplasia, Down syndrome, Ellis van Creveld syndrome, and such conditions as cleft lip palate. For our case report, a girl aged 12 years 9 months was referred by her family dentist for orthodontic care to the Graduate Orthodontic Clinic in University of Western Ontario. The patient's presenting complaint was the missing grown-up teeth and what happens next. Her general medical and dental histories were non-significant and she had no family history of any oral or dental anomaly. The patient was regular attendee at dental appointments and had no history of extractions. Extraoral examinations revealed a well-balanced face with normal facial profile and normal skeletal dental base relations. Intraoral examination revealed a class malocclusion. Intraoral examination revealed a class 1 malocclusion in the late mixed dentition. A 2 mm maxillary median diastema was present and the maxillary left lateral incisor was microdontic. Oral hygiene and gingival status were good and no caries was found. Radiographic examination confirmed that 12 teeth were developmentally missing teeth, and these teeth are 18, 17, 12, 25, 27, 28, 38, 35, 31, 41, 45, and 48. Significant external root resorption was found in the retained primary teeth. These are 7.5 and 8.5.
So, for our treatment planning, the challenges of hypodontia in dental treatment require consideration of its severity. Mild cases may be addressed with simple adhesive bridges or orthodontic movement of adjacent teeth to close gaps. In more severe cases, a comprehensive approach involving orthodontics, restorative procedures, and surgery may be necessary. Orthodontic treatment can relocate space, preparing for later conventional fixed prosthesis or implants. This case report highlights the management of significant hypodontia in an adolescent female, emphasizing the critical role of precise diagnosis and a well-coordinated treatment plan. The success of the intervention involving orthodontists, oral surgeons, and prosthodontists hinges on timely interventions and strategic decisions, such as delaying the extraction of retained primary teeth to preserve surrounding dentino-alveolar bone for future implant feasibility. The report underscores the intricate nature of adolescent hypodontia and provides insights for optimizing treatment outcomes through careful planning and coordination. The patient's complex malocclusion necessitated a collaborative approach involving orthodontics, oral surgery, and advanced restorative dentistry. A thorough consultation process and treatment planning were essential. Non-intervention was ruled out due to the severity of hypodontia and associated aesthetic concerns. Selective extraction or retention with build-ups of primary teeth were deemed inappropriate due to the malocclusion severity and poor root formation. Recognizing the limitations of a single specialty, a multidisciplinary team was crucial. Orthodontics alone was insufficient to address the spacing issues and occlusal asymmetry resulting from the absence of tooth 1-2. Collaborating closely with the patient, a comprehensive orthodontic restorative surgical team approach was adopted. The orthodontic treatment aimed to correct the malocclusion and align teeth in anticipation of subsequent prosthodontic care. A diagnostic setup facilitated the multidisciplinary consultation and a treatment plan encompassing orthodontics, restorative dentistry, and surgery was agreed upon the patient's consent. The orthodontic strategy opted for a non-extraction approach, employing a pre-adjusted fixed appliance system to achieve the treatment objectives.
Treatment commenced when the patient was 13 years and 1 month old. The patient was reviewed regarding her prosthodontic restorative needs during orthodontic treatment and before debonding, shown in Figure 3C. Debonding was completed when the patient was 15 years and 5 months old, shown in Figure 4A and 4B, Table 1. Due to poor aesthetics, teeth number 71 and 81 were extracted following debonding, shown in Figure 4A. Conventional orthodontic retainers with replacement dental units were fitted initially with a view to a long-term insertion of implants and placement of final suprastructure fixtures, shown in Figure 5. The orthodontic goal during both the active and retentive phases were achieved with good treatment outcome. The patient was followed in the graduate orthodontic clinic until maturation of her gingival unit and completion of her skeletal growth. 2 years after debonding, the patient was assessed in the fixed prosthetic and oral surgery departments for final management of the edentulous space. When she was 19 years old, 3 implants were placed at teeth number 12 and 45 and in the mandibular midline area. Due to the lack of dentoalveolar bone in the mandibular midline area, an augmentation bone graft was necessary and was carried out 6 months before implant insertion. Using bone harvested from the right external oblique ridge, no surgical complication arose and subsequently coronal fixtures were placed in teeth number 12, 31, 41, and 45, shown in Figure 6A and 6B. The microdontic tooth number 22 was built up to ensure symmetry with tooth number 12, shown in Figure 6A. For now, the mandibular left primarily second molar, which has good function, is being retained. In a long term, this tooth will be replaced with an implant as well. The patient, now aged 23 years, continues to be reviewed annually.
Hypodontia, microdontia, supernumerary teeth, and megadontia tend to be associated, and a number of researchers have proposed explanations for these associations. Brooke attempted to unify the etiologic explanation for these associated dental features, proposing a multifactorial hypothesis with genetic and environmental components. Brooke's model suggests that hypodontia and microdontia from one extreme on a scale, with megadontia and supernumerary teeth at the other end. His model explains that previously reported finding that males with hypodontia have more significant microdontia than females. This suggests that the wide variation in the presentation of hypodontia imply that the etiology is different for each case. They demonstrate that teeth located near ends of the peripheral nerve branches are most often affected by agenesis. They report hypodontia cases in which an orthophantomographic examination, tooth agenesis is associated with the absence of mandibular canal. They propose that in cases of ectodermal dysplasia and Ellis van Severald syndrome, the oral mucosa and supporting structures have a role in the etiology of hypodontia. In our case, microdontia was found in association with hypodontia, but no family history of hypodontia could be found to support a genetic basis for this patient presentation. No mucosal or bony abnormalities, which would have supported Kajar's model, were found during clinical and radiographic examination. This case report illustrates the need of a multidisciplinary team approach to care, not only at the treatment planning stage, but also throughout the entire course of the treatment. The main objectives in this management of any hypodontia case are to improve aesthetics and restore masticatory function. Both we achieve in this case. Given that the patient presented in early adolescence, the timing of treatment and the coordination of care were additionally critical components. Orthodontic treatment involved significant time, as implants and final prosthodontic restorations had to be delayed until gingival maturation and skeletal development were complete. Good coordination was achieved among all three dental specialties throughout the treatment. In cooperation with the patient, a combined treatment plan was agreed to. The patient was reviewed at planned intervals both during active orthodontic treatment and later during retention. All pre-treatment orthodontic goals were achieved without complications. Both arches were correctly aligned with coincident midlines. Normal buccal and incisor relations were restored. The results was both occlusally and periodontally stable, while allowing appropriate access for later implant insertion. Restorative and oral surgeries were timed appropriately, and both were carried out without complication. One complication arose in this management of this case. Pre-treatment bone levels in the mandibular midline area were low. Further bone loss occurred following extraction of the primary central incisors and before implant insertion, resulting in definitive need for dentoalveolar bone augmentation. Carrying out the two mandibular primary central incisors extractions nearer the time of implant insertion may have been a better option. However, for patient aesthetics, these teeth were removed and aesthetic replacements placed on retainers. Conclusion: marked hypodontia demands coordinated treatment planning and appropriate timing of delivery of care by various dental specialties. Management of hypodontia in adolescent patients permits optimum orthodontic control of the developing occlusion. This literature review and a case report of hypodontia illustrate the principles of case management. Multidisciplinary referral or consultation is important in treatment planning. Planning for space management is best carried out before initiating orthodontic treatment. A diagnostic setup is an essential adjunct to the treatment planning process. Tooth size measures provide valuable data for evaluating the final tooth position and morphology. Careful consideration should be given to the timing of extraction of primary teeth, and if possible, extraction should coincide with implant insertion.
Thank you for watching.